It's an honor to me that you were the one who was championing this online access. You know how I am feeling about this and meeting member and this and all over this discussion, how we could delay it. So most of the practices have managed to delay by till 28th of November. And after that, how things stand, if the government doesn't do any further amendments to the legislation, then the providers will automatically switch it on to all of this. So I understand that you receive lots of benefits to the patient.
I understand.
And as well, yeah. But overall, the majority of GPs do not think like that. So why do you think that you champion slightly differently and how to convince other GPs that this is the best thing to do?
Okay, so again, as a full-time GP, I am doing 12, 13-hour days, and it's getting harder and harder. There's no question about that. In the last 22 years, it's been hard. I've never known anyone ever complain about how easy it is. They've always said it's hard, but for some reason, in the last year or two, it's become even harder. There's some reasons for that. One, of course, is that one of the successes that we've had as a result of all the care that's delivered is that we've got people that are living longer and longer with more comorbidities, which I think is a success and something that we should all be very proud of. Just to give you some idea, at the end of the 19th century, the average life expectancy was 40 years. So we've gone from 40 years up to 80 years, but that's brought some significant challenges with that, because whereas before, I remember as a SHO, FY2 doctor, looking after the chronic care unit, that we would probably admit 6 or 7 heart attacks a day. A night. And now you hardly ever hear about anyone who's had a heart attack because of the huge advances that we've had in treatment. But that's come as a cost. And the cost is that you can now save your life if you're having a heart attack or a stroke. But the problem with that is that you're now living with the fear of having another heart attack and stroke. And that has a mental anguish upon you, which then comes to us as GPs. On top of that, for the last 2 years, while the hospital sector was able to shut down and close, we as GPs have continued to work all the way through. So we never had any time off to be able to relax. We've had to work all the way through. And whereas at the start, people were clapping outside their houses saying thank you to the NHS and GPs, that's all gone out the window, and now we're in complaints. And at the same time, we've got 8 million to 7 million people who are now waiting to be seen in secondary care. And the moment that you're waiting, that creates more fear. And typically patients are waiting 9 months, 12 months, 18 months. Where are they going? Because the hospital just said, sorry, we can't see you. All those patients are coming back to us again. So all those things are adding more and more pressure upon us. Of course, if you're waiting to have a hip replacement, then accessing your medical records is not going to help you. But that's not the way I'm looking at it. The way I'm looking at it is when you join the surgery, and the nurse measures your height and weight and blood pressure and things, and gives you smoking advice and alcohol advice, and advises you at that point there you should try and cut down how much you're smoking, you should cut down how much you're drinking, you should try to lose weight. There lies the key in your medical record, what you can do to help yourself. When people say to me, why would a 20-year-old need to look at their records? I turn around and say, because they've already started to adopt certain lifestyles. If they don't change, they are going to go on to get long-term conditions. Okay? In my practice, my patients die 10 years younger than the national average. But that doesn't tell the whole story. They might be dying at the age of 60, but they're becoming unwell when they're 40, which means that they're only having 20 years of good health, and then they're spending all their time in GP surgeries, starting with blood pressure, then getting diabetes, then getting ischemic heart disease, then getting heart failure. Right? And they're spending 20 years of ill health, and then they drop dead. Let's remember how, Prince Philip was 99 years old and still driving around. That's the picture that they saw on the television, but that's not the picture my patients see. They have 20 years of ill health. Now, if we could take that 20-year-old and maybe perhaps, as a result of them looking at their records, recognizing this might help them for the future because that nurse or doctor has advised them something, and they read that bit of information and follow it through to see how they can actually change things. And my patients and those families are appreciating it massively. That grandparent who can't speak a word of English, who comes to see the doctor or the nurse and says, you need to do this, this and this. I'm getting the grandchild who might be playing video games on their smartphone and say, listen, would you like to be able to access your grandparent's records? Get the consent from the grandparent, and then ask the grandchild to say, do you think you could spend 5 minutes every month, put a reminder on your phone to say it's time to order the repeat prescriptions for the blood pressure, for the clopidogrel, for the aspirin? Because if they take that medication every month, guess what? They reduce their risk of having a heart attack or stroke by a third. That's what we're talking about. Activate the family. Families help families. No one else gives a monkeys. Do you feel confident that the surgery is going to do an audit to check whether you're taking medications or not, or your parents' medication? Or are you going to check because you care about your parents? Activate the family.
Thank you very much. I think someone already did ask a question about the access that we already had, or patients had. So I just wanted to verify that patients previously had access to notes but only read code entries and online prescription, which majority of GPs thought that was enough. But now this is a new debate, so I think we will move on from this online record to the next one. So that's okay, thank you. Shall we maybe, because I want to involve as much of you as possible, ask everyone maybe to tell what role you are, because I'm still not sure whether how many GP trainees have we got in the room, or partners, or salary, excellent. And in your view, if you could just talk about briefly, 1 or 2 minutes, I mean, what do you think is the major issue, or one of the issues that you think general practice is facing, and also propose a solution? Because there's no point in talking about the issues or problems if you do not have a solution in mind. So I think I would like to start with Dr. Amajoni, if that's okay. Just like briefly, we've heard you before, and I missed one of that. Just briefly, one issue and solution. And then
largest practice single site here with 30,000 population. Of the 30,000, 80 to 90,000 they don't speak English. So you can imagine the challenge we had when before that we used to walking. So everybody in the morning was walking and they were sitting there and then we see them. But when the COVID came, these restrictions, we had to switch everything online and Zoom. So we installed 30 by the phone. They were calling you management. And then now the new thing is now again face to face coming to play. We had a challenge whether we should again open the doors or we manage as managing it and only make coming when they have appointment. That's where Arshad asked a question about teaching patients. So what we've been doing here, so since we opened the door, there are a long queue phone calls. You want 13 on the line, you working online. So what we did, we work with applications, so that's online on the website. Because when they don't speak English, we would not encourage them to ask rather than speaking with somebody else. It didn't work that way, and then we noticed that now certainly opening, walking at but what we did is we put 4 or 5 computers here reception area. And we got the girls who speak their language, who said, we're not going to put you appointment, you have to fill this form, we're going to help you with that. So they go on the computer, settle the reception, they fill out the form, and the girls help them. And then we book appointment, whether it's phone call, whether it's face to face. So with that, and now they are learning. So I think the learning curve, you have to pursue it, you have to basically push them harder, you have to be strict. That you cannot book appointment like that, you need to fill out that form. That is what kind of condition they have. So with that, we are kind of moving forward, and quite a few of them, almost 60-65% people are doing engagement. And it's kind of hard work, but it is doable.
so I think it's innovation again, and online consultations is one of the ways to decrease pressures and access, or increase access to online consultation. Thank you very much. Move on to Rishi.
Our GPs are scapegoated. Comment here, say, I think it's incredible because if you look at your patient population in your area, there is a large number of patients who don't feel comfortable talking on the phone. So giving them that space, that any GP setting, where they do it with the staff, they're doing the same thing which they are, what's the barrier, why they're not doing it, why they're not taking up the support. And most of the time, it's your front desk staff. And I think what I really feel when you said there's no uniform training, that's a very important job. For example, if you dial 999 for support, there's somebody sitting there with hours and hours of training and support, how to do that, how to make hiring, and then move them to the right path. The same can be taught in your reception staff, and know assess them, where to direct them, but then there's a uniformity across, so the patient will go on application.
Very good
I
point.
think very good to point you mentioned.
Thank you.
So I'm Sadia, I'm GP partner. We should have 10,000 patients with both our partners. I think I will discuss a brief piece of work we recently done for health inequality for our PCN, because I'm health inequality lead for our PCN, which is 50,000 patients. The work is basically two. It's made for South Asian people who are. We noticed that they are not accessing healthcare facilities in primary care as compared to the general population when I said the white British. So we divided our work into two stems, and one of them is exactly that we are training our practice staff, front door people, because it looks like there is always a barrier for these people. Booking an appointment, going to see a GP, it looks like a hard work for my mom or someone who can't speak English, and it looks like there's always a barrier, and they find it very hard to communicate. So we're just trying to educate our reception staff. We recently done a campaign as HI, Health Inequality High campaign. Be open, ask them if they had a language line. In fact, we hired 3 receptionists who can speak multiple languages, and then we can ask them to find the time if someone is struggling with their language. So just go and just take them on the side for 5 minutes, help them. There will be loads of issues that we want to discuss. I'm always open that they can book those patients with me and speak Urdu, Punjabi, English, little bit of Arabic. So I think we need to work on these small issues to make a big change. We are following clocks, we are achieving all our targets, but these patients are still being neglected. So
Health inequalities is a goal. And when I must give credit to you, as we got this idea from you when you mentioned that you recruited some Polish front reception guys to you a couple of years ago, and that really has been a success. So I think if you have got a practice of veterinary minority language, then I don't know if you might have some stuff from the similar background from us who can speak their language.
So we developed Bengali patients. We employed a Bengali receptionist and it became a nightmare. She was actually a young person, about 22, 23 years old. The problem was that with the queue of 5 people, and the 6th one was auntie twice removed. She said, so-and-so, get me an appointment. And she didn't get an appointment. When she came home, her mum would tell her off and say, listen, so-and-so was complaining when she didn't get an appointment. It became a nightmare to actually manage. That's the problem.
The pros and cons of both. It's a good point. Thank you. And Sarah, introduce please.
I'm Dr. Asma Bukhari. I'm a single-handed GP principal of a 6,800 practice. I do not have any partners. My area is not deprived. It's middle class.
Where is it, sorry?
It's in Leicester.
Leicester.
So Hisham and undeprived areas have their own challenges because they think they know more.
Yeah.
So they are complain more. My very bad experience when I started as a partner in this practice was going and seeing a patient who was on palliative chemo, and I saw criteria was not for admission. Unfortunately, after 5 hours, the patient died, and it was my first experience going to coroner's court. And to explain myself, I was almost in tears when the family looked at me as if I killed the person. And the first thing that came to my mind was, this population does not accept death. And it has been past 7 7 years I've been trying to educate people, and COVID got me the best opportunity. When I spoke with patients, I told them there are two guaranteed things in your life, your birth and your death. You can't change it. It will happen. Where it will happen, you don't know. How it will happen, you don't know, but guaranteed. Other things, unguaranteed. So that was one thing that I achieved. Second thing is partnerships. Why is government thinking that partnership is good? Because we are good leaders. You look at so many NHS trusts, hospitals, they are going into red because there is no proper leadership. But a partnership, whether it's me, I'm amazed at your innovation and I'm going to learn from you, but you come from big teams where there are people who are helping you. I am only one person and I have to do this innovation on my own, and I would really like to learn
Sham
more.
said that, I started I qualified, and within 2 months after qualification, my first job was to take over shipments practice. And the practice said to me, you go in there, because they were always used to only one doctor, so there was a large practice. I went in there, I had to learn to either sink or swim. I guess I learned to swim.
Yeah.
The point is, I worked as a single GP in that one practice.
Does everyone know who Shipman was?
Yeah.
Anyone who doesn't know who Shipman was?
Okay, you need to read about it.
So you are a PDP.
Are you guys are medics, right?
Yeah, I'm GP.
Okay, so you need to remember, Shipman is the guy which is why the portfolio came out, which is why the
Although they say that
Shipman is the guy
it's not because of it, but it has an
people,
impact.
and this guy walked in and took his practice over, which no one in the world would want to touch. This guy went in and took that practice over.
I tell you, the battles I'm facing
Same
now,
with it.
the battles I'm facing now, that quote, NHS England will not be happy about it. The battles I'm facing now are far more difficult than what I had to deal with 20 years ago. But I guess that was good training for me to understand how to deal with the situation.
Thank you. I think
One more thing, life is very difficult, but it is why we became doctors is keeping us going. In COVID time, when hospitals were shut, we were working. One thing that I will just take example of diabetics. Those who were very well controlled, within 1 year, from 6.57, they went to 10 because they stopped looking after themselves. And for past 2 years, I am trying to manage those diabetics. I can say a lot, but
Thank you very much. And just to clarify that it's not only the government that doesn't want the partnership model to continue or survive, it's mainly through the feedback from the GPs. Not many GPs want to be partners in the current circumstances that we know, even the GP trainer and the GP trainees are coming. So I must salute you to be a single-handed GP, ethnic minority woman, and excellent.
and a GP trainer, a medical student trainer, and a appraiser and a PCM lead as well. I don't know how I'm doing it, but I'm doing it. One thing I would say, I like the quote of think of the end before you start. I think our NHS has not thought about the end because with this online access, they have totally forgotten the implications on us as GPs because there are ethical implications and legal implications. And do we have time to deal with them?
I think very good point, and I would advise that you don't tell GP that you gave government this idea to give people an online full access. People are so upset with the...
No, that's why I'm on the radio. That's why I said.
When
That's
you
exactly why I'm on the radio.
I rank myself.
My back was going
On system 1, when you complete the consultation, when you say it, a window comes. Do you want it to be seen by the patient or not? And if it is not, I just say no.
Just can I, Jawad? He said the trainees don't want to be partners. We had a discussion at the LMC. Do you want to just say what the trainees, just introduce them?
I think we'll come to Jawad in a minute, so let's go and...
It's just, you know what you said, that people don't want trainees, don't want to be GP partners. I just want to challenge that a little bit, because
I
the
think
trainees are saying...
because we have a data from the GP committee,
Yeah.
who's the only committee that represents GPs in all of the country in every capacity. So they've got sessional GP committee, subcommittee and trainees. So current workforce, if you look and you've shown us the data, the partner numbers have gone down. And there are a number of reasons due to which perhaps have people who all, not everyone wants to be partner. There are many people who are actually interested in partners. So I must say that's, I think it's not like an absolute thing. But of course, due to the lack of interest, it must have gone down. We will come to you in a minute. So let's move on to the next doctor or trainee. Or
I'm so sorry, but it's got very quiet outside. The reason for that is because our police could be starting a session where they were having the GMC and the GPMA and everyone else inside of there as well. So we've got a choice whether we can actually continue over here if we don't want to go and attend that, or whether we complete our sessions over here as well. So Dr. Ansel will probably,
I think let's carry on then. I think if it is a collective thing, it might be useful to be honest. I personally would prefer to go to more like a collective. I personally prefer to be over there. To more like Bob. Yes, okay, that's fine. Then we'll carry on. Yeah, just another 10 minutes maybe, so we'll try to be quick.
My name is Dr. Nashmi. I'm GPST 3 previously, surgical background. Anyway, so as a trainee, we don't really have a lot to share in the practices and all, obviously feedback is. But I think what I would like to ask is, and a couple of comments, I think we have emphasized a lot about language barriers and all, but I think one major population we have missed out is the elderly local English people as well as at 90, 80. They are not as well versed with the internet. Like we were in a diabetic setting, the group we are setting up at the surgery. And this lady, 88-year-old, she was like, oh, I don't use the internet, I don't have a smartphone. So what measures do you have in place for people like her? Obviously, as you said, you have got this online portal. She's not happy to use that. First is that. Secondly, when we spoke about, obviously, you have done a brilliant work in your practice. Are you supporting your local practices to take that model on board? And is that something that can be made national? Because obviously, if we have a framework in place, it's very easy to replicate it when we are built on those new start afresh. So what are your takes on that?
Rather than answer the Q&A where we're answering every question individually, should we ask everyone to just give us their questions and then see if there are any common themes over there, and then probably go ahead and do it that way?
This is to be more time efficient, conscious of the time.
Can I make a comment? So we're going out the table. So I'm not and I'm a GP partner based in a very big partnership with 35,000 patients. And we've got about 10 surgeries. So just two comments. The first is the personal comment about the NHS access to records. I would say I find it personally very difficult when writing notes down. I can only for example, I used to use smells of alcohol or things like that I probably wouldn't do now. So that's something personal. And the second would be that we talked about patients not being able to access because of their language and who they are. But I'm a champion for carers, which means that carers, so your surgery should not only be patient-friendly but carer-friendly as well. And what that means to me is that this study innovation a couple of years ago, I also got the prize for it, was I set up a carers clinic in my surgery. And especially with patients who don't speak the language, I brought them in and their carers to make sure that we empower both of them. So it would be something which I would want to see rolled out across. I've taken the message across most of because I represent the West Midlands, so I've been to lots of surgeries putting that forward, but it would be something which I think is equally important. So we always say it's the patient, but we always forget the doctor. That's equally important. So that's just my thoughts.
So I think that my common patients, carers and information are the most underutilized resources in the NHS.
I just have one thing to say. I'm basically working in tiny homes on a ST1 basis. So I just started. So I have seen a few times patients coming and they have previous blood because in tiny homes we are seeing patients who are pretty normal. And most of them are coming and they have get their blood done before, investigation done before, but they don't know the results at all. So when they come here, they'll just say, oh, my doctor did that, but I'm not sure what was the result. Or even they said everything is okay, everything is fine. So I was thinking about when we were talking about data and all that. So this came into mind, maybe we can have a safeguard regarding with the bloods, investigation, everything is normal, we can let the patient sleep.
Even if it's abnormal.
So basically,
Even if it's abnormal, as long as you put the safety net in
no,
place.
so before that, you don't even need the safety net. So, like as per me, I made the wrong here. So if everything is all right, everything is, all the bloods are fine, and the GP has reviewed it, we may let the patient see without even the safety questionnaire. And if there's any doubt or anything, or if there's bloods investigation, which they might need another consultation, or they might need to speak to GP. In that case, we can have some safety guard there to tell them.
The only problem is sterile pyorrhea. You can only access that's normal, but actually they've got TB. And so 5 years ago, 6 years ago, and I'll share it with you, patients asked me, said, listen, Dr. and I'm looking at these test results, I don't understand them. And so what we did was we put a talk on to help them to understand what the test results are. And so when patients, and it's on my website, and I'll send you a link if you like, but basically it helps them to understand when a normal result is not normal, or when an abnormal result is normal, which is the other big problem. You know, it's slightly out of the size of normal range, but it's normal. And it's helping patients, and also the other thing is, we don't look just at the individual result, we look at the trends. And secondly, we also look at the whole picture. And so you have to teach all that kind of, now the reception staff are not going to be able to do that. And that's why the minute you start thinking about this partnership of trust, where you're teaching that patient or the carer, help them to understand what results means. It's not just as it's normal, tell the patient, because you'll run into problems.
And I understand what you're saying, but I'm talking about the high and low risk patients who don't need that. For example, someone who's taken just for FBC, basically hemoglobin levels, and very normal things that who are which are not serious.
I'm not very negative, don't get me wrong, but you can start with a simple cough. That might be a URTI, it might be LVF, or it might be lung cancer. There's no, and that's the problem in general practice, is they don't have something on the top of their head that says, I'm low risk. That's why there's a real challenge around this, which is why we've got to get into shared decision making. And the idea of just automatically switch on and see it is highly dangerous. That's why I've always said, look at the result, but look at the consultation that the doctor who arranged that test result was for. What were they expecting? And start to put information in there around what they should do. It's a different way of thinking. The minute you start thinking that you're writing for that patient, for them to understand. When trainees come to me, they start writing all sorts of abbreviations because they're doing doctor speak. I tell them, say, listen, 83% of our patients have got full access to medical records. When they ring the front desk and ask them for the test result, they go, no, go online and look at your results yourself. Try and understand it yourself, and if you're still unsure, then get back in touch with us. It's a different model. Think about yourself. Will you be happy to do a clinic where you're just looking at the test results? Or would you want to be able to see the consultation, the letters, the scans, the previous consultations? If that's what you would expect, why would you expect the patient to have any less than that? That's my argument. That's what makes it safe.
Absolutely.
Can I add something? You spoke about safety netting. I
Yes.
think there one safety netting is like this. When the GPs are filing the bloods, we would always know, isn't it, as Dr. Manam?
Well, if you look at the consultation and everything else, but the number of test results that are coming through, we haven't got time to look at everything. That's why it's not safe. That's why it's not safe. That's why locums are refusing to just look at test results or even sign prescriptions, because they don't want to take responsibility for that.
Yeah, the risk is, you know, if you check the safety net right, the blood test results are all right, some patients will stop taking medications if I'm all right.
Yeah, thank you for that. And we move on to next patient. You're not training? Oh, GP, okay. Arshad, you missed some of the things that we went on. Anything? Your question, I really liked it.
We've had discussions before, and
And you know,
we've had discussions before.
Vishal, can I ask, you said there's a GMC session? Has it started or?
I think it's starting in about 5 o'clock.
Will you all be there?
You've got three, yes. I think something close. Anything else you want to add as
I'd just like to say a big thank you to everyone. Some of our attendees have had to move on because they were taking part in other activities in the session today. But thank you very much to everyone who's come on board over here as well. PAP GP is a subgroup of Apni GPs. Apni is a membership organization. We've got about 5,000 members plus right now. 500 of them are all GPs. We want to get more GPs to be involved, and we're going to be doing activities up and down the country. Answer will be playing a big part in that, and I'll play another big part in that, hopefully, by Robin and Amir as well. So we're going to rope everyone inside, so we're going to become a more proactive organization as we keep growing. We've had about registrations for about 50 odd people. I think only about 30 or 35 have attended. But nonetheless, I think it's a fantastic event where we talk about lots of things. Practice change in terms of improving the front desk, practice change in terms of effectively using your pharmacist, practice change in terms of giving access to records, practice change in terms of knowing what the GP numbers and the challenges are, and the fact that we have to innovate or we won't survive or we'll die quicker than what we're doing. There's a beautiful word which was a couple of words when we were describing the NHS, and we call this as a spiral decay. And what that basically means is it's spiraling, but it's not spiraling fast, it's spiraling slow. And while it's spiraling, it's decaying at the same time as well. Now, things are going to change, and I was involved with the primary care lead for the Midlands. The Midlands covers all the way from Staffordshire all the way up and about Sheffield and further down to the west. And I asked what's going to change. Thank you. It's becoming. So I asked him, I said, what's going to change in the next couple of years? So the CPT conference, that's going to be a big change. We don't really know what's happening, and even they don't know what's happening.